Welcome, and thank you for joining us. My name is Audrey Hassan, patient liaison for the MDS Foundation, and I'll be moderating the presentation today. Thank you to Bristol Myers Squibb, Jazz, Novartis, and Taiho for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Andrew Bruner, an assistant professor of medicine at Harvard Medical School, an assistant in medicine at the Center for Leukemia at Massachusetts General Hospital, located in Boston, Massachusetts. His research is focused toward understanding treatment patterns and patient outcomes in MDS, along with other advanced hematologic malignancies, and to develop new treatments for these patients. He is involved in clinical trials for all stages of MDS and its related diseases, with an overall goal of tailoring treatment to improve the outcomes of these patients. With that said, it is my pleasure to introduce Dr. Bruner.
Hi, my name is Andy Bruner, and I'm a medical oncologist here at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. I'm here to talk to you today about understanding clinical trials in myelodysplastic syndromes and really looking at recent studies from our annual meeting, the ASH annual meeting just done in December, and talking a little bit about how to choose a clinical trial in light of thinking about it from what studies are ongoing and what might you be thinking as a patient in trying to approach a clinical study. Here are my disclosures. I do consulting and am involved in research related to a number of early stage compounds in MDS and AML. So when I think about MDS, I really think about it as a spectrum of diseases. It is a type of blood cancer, but really under the umbrella term of MDS, there are many different presentations and also different risks that we associate with a disease. MDS can be defined based on its clinical characteristics. So some patients will have certain pathological criteria, or they will have certain features that speak to a course. Maybe more patients will have an anemia-based MDS course. Some patients will have disease that acts a lot more like leukemia. There can be variation in what types of blood counts are low. So some patients will have really low white blood cell count and have recurrent infections. Some may have a lot of bleeding complications from low platelets. And the majority of patients, however, either regardless of their disease, will have mostly anemia or low red cell count as their presenting symptom and really as the treatment modality focus that we look at. If you look at our understanding of MDS, it's also come a long way in the last 20 years. There's a lot of different mutations that happen in stem cells that give rise to MDS. And the different patterns of mutations that we see both can be targets for some of our therapies, but can also lend to a different understanding of prognosis, of the natural history of disease, and of what kind of interventions we might want to consider and when. So whenever I approach somebody who has a new diagnosis of MDS, or I meet some patient who is curious about their type of MDS, really the first step is asking, what type of MDS do I have? And this lends itself to understanding what kind of clinical trials might be relevant to you. Whenever we have a new possible MDS case, we want to look at what blood counts are low. So MDS patients have low blood counts because their bone marrow cannot make blood as effectively as a healthy bone marrow. We want to understand the mutations that are present. And so really that requires a full cytogenetic analysis or a full karyotype, looking at how the chromosomes in the cells have been altered. There are certain treatments that focus on one chromosome alteration over another, for instance. We want to get a bone marrow biopsy when we meet a patient with MDS. Bone marrow biopsy provides us the clearest information of how the bone marrow, which is that factory that makes blood, how it's functioning, and what kind of blood cell maturation problems might be present. And we also want to look at what other point mutations are present. So While chromosomes can be abnormal, we have increasingly learned that specific genes that are responsible for blood cells maturing and creating healthy blood, they can have mutations in them from many things, from living a long life and cells dividing enough that they gather mutations, or from exposures like chemotherapy, benzene, radiation therapy. And so we want to understand all these components of disease to try to estimate what is the likely natural course that a patient has if we did nothing, because that can inform when we want to intervene and also what kind of intervention we may want to make. And there's a number of ways that we can risk stratify patients. Historically, that's been through risk scores like IPSS-R, or there are a number of lower risk scoring systems, low risk prognostic scoring system, or WPSS, and increasingly how mutations may play a role in understanding the natural course of disease. So here's an example. This is the IPSS-R score. I ask my patients, I talk to them about what score their disease is. This is a freely available score that's available online. You can plug in your blood counts and certain elements about the bone marrow biopsies, the number of blasts in the bone marrow, and the chromosome abnormalities that are present in the MDS cells. And based on that, you can get a rough estimate of what would happen if I just watched my MDS. And you can see that there's a wide range of things. Now, MDS is mostly a disease of older individuals, but in general, people who have lower risk or very low risk MDS, they live with their disease, and they may live many years, but they may slowly develop complications of their disease, most commonly anemia again. People who have higher risk features of disease, their MDS is unlikely to stay quiet. And so they're more likely to develop complications over the next year or two if we don't do anything. And so when we take that IPSS-R or IPSS score, we use bone marrow blast count, chromosome abnormalities, and blood counts to try to put people into essentially two camps. Patients who are going to live a long time with their MDS and for whom we might do symptomatic intervention, and people who have what we call higher risk MDS. And higher risk MDS really means we're worried that without intervening on your MDS, you're likely to start developing a risk of serious or life-threatening complications, such as infections or bleeding. Or we're worried that your disease, if untreated, will turn into a more active form of bone marrow or blood cancer called acute myeloid leukemia. And so there's a lot of ways that we historically define high risk MDS. So using the IPSS-R score, for instance, or the IPSS score, which predated that. But there are some other clinical features that we think about that can really contribute to our concern that you have higher risk disease that's not going to stay quiet. Some of those include the fact that your disease is changing rapidly. So somebody who, even though they appeared to have low risk disease, if all their blood counts are dropping quickly or their blast count is rising, maybe it's not behaving how we would expect. And really that should be a signal that we need to change what we're doing. Increasingly, though, we're also understanding that much of our understanding of risk also depends on point mutations, specific mutations in the stem cells that are typically acquired over a lifetime or due to an exposure. Some of these mutations we've known about for some time, like a mutation in a gene called P53, or other mutations that can be higher risk or that are more seen in AML. And those mutations have increasingly started to inform how we approach somebody. And also even there are mutations that are driving our selection of patients for clinical trials. So it's really increasingly important to know whether you've had mutation testing. And also if any of those mutations are either currently targetable or may play a role in clinical trial selection. So when I think about MDS in 2022, and again, this is just a very thin framework, kind of trying to go over the overarching picture of a patient presentation. When I meet somebody, I like to know what is their disease right now and what do I have to worry about immediately? Is this disease going to be quiet, something that they might live with for a long time? Or is this something that we can watch it maybe for a little bit, but it's likely to start changing and start impacting their quality of life or their longevity. And in this year, we have some updates on how we diagnose and prognosticate for patients that I'll go over shortly that may impact how you are enrolled on a clinical trial if you're interested in that. We roughly group people into lower risk disease, so patients who have symptoms from their MDS or may live with MDS, but really symptom control, management of low blood counts is really what our focus is going to be for those patients. Or patients who have higher risk disease that's going to cause problems in the near term. And in people who have higher risk disease, we really try to think, what can we do to change that natural history? How do we make you live longer with a better quality of life? And there are two basic strategies. One is determining whether, are you somebody who is eligible to just replace the bone marrow completely, do something called an allogeneic transplant, where we take stem cells from a donor and give you chemotherapy, get rid of the bone marrow, and give a new donor stem cell population to repopulate and be your new source of blood and new source of immune cells and red cells and platelets. If we don't pursue a transplant, or if there's some reason that you're not eligible for a transplant, historically chemotherapy, azacitidine or another drug, decitabine, we often term these hypomethylating agents or DNA methyltransferase inhibitors, or they have other names as well. But those have been shown historically to have an improvement in survival and also improvement in quality of life compared to people who receive mostly supportive management. So many times with higher risk disease, those are the basic strategies. In contrast with lower risk disease, we're thinking about how do we manage low blood counts, your anemia or your low platelets, and what can we do frontline, as well as what can we do if patients have relapsed from their treatment. And a lot of our trials are set up really to understand either first-line therapies or treatments that people have been on prior therapy, but now they need something new. So we have talked a lot about how mutations increasingly inform our trial selection and also disease risk. And disease risk, again, defines what kind of trials you might be eligible for. So do you need a disease-modifying trial for higher risk disease? Or do you have lower risk disease that really any trial would be focused at anemia alleviation or treating one of your low blood counts? Recently at our annual meeting, we had an update. And this is really building on a lot of work that has been put into understanding how certain mutations may influence the natural course of disease. But we looked at a large group of about 3,000 patients. Dr. Bernard and colleagues really spearheaded this. And they profiled genes that are commonly mutated in MDS. And they compared the natural courses of disease for patients according to the mutations that were present, as well as features that we know matter for other types of MDS, the IPSSR score, blood counts, blasts, these kind of chromosome abnormalities. In looking at this group of patients, they followed them for survival, and they assigned their risk group based on their risk of death or of developing leukemia. And so if you look at the scoring system, what it finds is there are some patients, very low risk or low risk, where their disease is very slow developing. They are going to live with their disease for a long time, many years. And supportive care is probably the most appropriate management strategy. But there are other patients who have high risk mutation features who really, we should be thinking about interventions. And this is a new prognostic scoring model that would allow us to divide our clinical trials again to try to understand who really needs a chemotherapy or a transplant-based approach that will try to change the natural course, move that survival average from 1 year, for instance, pushing out so patients are living longer with their disease. And which patients do we really need to focus on trials that might be more focused on their symptoms of disease, their anemia or their low platelet count. So when I think about a clinical trial for a patient, one, I'm thinking about what they need. So what is the standard of care available for a patient? And then really what kind of trial might make sense for them. And when we approach a clinical trial, we talk about trials in order of phase. Now, in cancer care, almost all of our studies are meant to explore benefit and look at what we think should be an active agent. Phase 1 studies are typically looking at what dose of a drug we need to get to make sure that people are being exposed to the drug at a high enough dose that it might work, and also to make sure that it's safe in patients. And phase 1 studies can embody a large spectrum of studies. Usually they are either combined with a well-known drug, so you know that you're at least receiving a standard of care established drug, and they're looking at the safety of the combination, or they're in the relapse refractory setting where patients have been on prior treatment, and we're exploring whether a new target may be viable. In phase 1B or phase 2 studies, we're often then taking any signals that we saw in those early phase studies, and we're expanding that study patient population to try to see, can we see more efficacy? Is this drug, does it seem to be effective in a certain group of patients? Does it show responses across a number of patients that would merit bringing it into a larger group? So usually at that point of a phase 1B or a phase 2 study, we have an idea of what dose of drug patients need. We know kind of some of the basics around its safety in humans. And we're looking at, how active is it? Is this drug something that really could change how we approach MDS? And then in phase 3 larger studies, this is really our proof. This is where we compare things head to head to try to say, we've got a standard of care. Can we compare that to this new drug or a combination and see if we can beat the standard of care to really advance the field? Often these phase 3 trials will be randomized and blinded so that you may not know what of the drugs you're getting. And usually these trials are rested on a point of what we call equipoise, meaning I really can't tell you if one strategy or the other is better. And that's where you should be thinking about for a phase 3 trial, because we should not know that something is better or not. And historically in MDS, azacitidine and kind of as a correlative decitabine, but is no other drug has really shown improvement against azacitidine outside of stem cell transplant. And so if we're thinking about how do we improve upon our standard of care, we're often saying we don't know which one's better. And that's the scenario you want to be in for a phase 3 study. And so again, for higher risk MDS, many of our trials are in this space because we have not unseated azacitidine or decitabine for the last 15 years from their standard treatment. And so what do I think about when I'm approaching somebody and thinking about a trial in higher risk disease? Well, first of all, we have to know what our standard of care is. So some of the studies that we've done in the last 20 years as a field have been to first identify that azacitidine, for instance, is a drug that, if administered, improves survival compared to conventional care. And conventional care could be transfusion support, it could be low-dose chemotherapy, it could be leukemia-style chemotherapy. But in this study, now over a decade old since published, AZA-001 showed that patients who have higher risk disease, who start on azacitidine, have a survival benefit compared to those who get other therapies. And so historically, all of our frontline treatments of high-risk MDS have looked at some azacitidine-based strategy or a combination of a drug plus azacitidine to try to unseat azacitidine monotherapy, which is our standard. The other standard of care that I think has increasingly been proven over the last 20 years, although there are moving field goals for who is actually eligible, is the use of allogeneic transplant. And I think that a nicely done study, the BMT-CTN 1102 study, kind of confirmed what we long suspected, that if a patient comes to you with higher risk MDS and initiates an early transplant strategy. So tries to find a donor and goes to transplant early if that donor is available. Those patients have a better survival than patients who are maintained on chemotherapy early and don't have an early donor option. And I think a couple of things have changed in transplant that make every patient probably worth at least asking the question, should we think about transplant? One is that we're able to transplant patients with gentler conditioning regimens and patients who are older and have more comorbidities than we could in the past. So it's really important not to limit yourself just solely based on age. Age is a number, and it's the whole person that we have to think about. And the second is almost everybody has some donor option. And I think that donor availability has changed dramatically, where we used to really focus on fully matched related or unrelated donors. Now we have a lot of half matches, mismatched donors. We have better ways of conditioning chemotherapy so that we can permit these other types of donors. And so once we've established the standard of care for higher risk disease, we have to think about what really are the goals that we're doing for a specific patient. So am I aiming to cure this disease? Or am I trying to get the longest survival with but I don't want to sacrifice certain parts of quality of life? Am I a transplant candidate, or is this something that I don't want to go through? How quickly do I need a response? All these questions factor into what kind of clinical trial you might be thinking about with your doctor. For instance, if I'm going to transplant, should I go directly to transplant, or should I think about some chemotherapy prior to transplant? So this is an interesting study showing that yes, indeed, transplant has a benefit in MDS. For patients who are younger and going to get a myeloablative regimen, so a more intensive chemotherapy prior to the transplant, those patients seem to do very well, even if they have, with a low rate of relapse. In contrast, if I'm not able to get a full intensity chemotherapy conditioning regimen, the relapse rate can be relatively high depending on the type of MDS. And so I think as a field, we are increasingly asking, are there things that we can do from a chemotherapy standpoint to optimize disease or to change disease so that something like a transplant would work better? Can we eradicate the amount of disease burden at transplant? And I think some of the areas where we're looking at in MDS, although they're still exploratory, are can we reduce the amount of measurable disease prior to transplant, or make sure that disease is gone after transplant, and if not, intervene early, because those patients seem to have a higher rate of relapse. And so all of this gets us to kind of this backbone idea in higher risk MDS, where the first thing we're asking is, are there combinations that we can add to azacitidine or modify the azacitidine regimen somehow so that we have a better chance of getting a deep remission and either prolonging survival with that combination alone, or if we're going to go to transplant, can I optimize your disease better so that you're less likely to relapse after transplant? And there's a lot of challenges in identifying a promising combination. First of all, azacitidine works on its own. And so when you are combining another compound with it, how do you know that this is really something that's active? And a big challenge for us is that in phase 1 studies, early phase studies, or even phase 2 studies, it's really hard for us to know with certainty that this is going to beat azacitidine. So here's an example. If you have a 10-patient trial, the chance that we'll double the azacitidine response rate from around 15% up to 30% to get a complete remission, you'd need to see a lot of remissions in that small group. 7 out of 10 really would need to have a remission in order to feel like, wow, this is a really active agent. Doesn't mean that you couldn't see 3 out of 10 and it'd still be more significant. It's just to be confident when there's only a few patients on a given trial can be really challenging. And it's one of the challenges in MDS trial development that we don't always know early on whether this is going to be a home run. So here are some of the trials that were presented this year. And I think that this combination study, adding a drug called pevonedistat to azacitidine, exemplifies some of these challenges that we have when we try to develop new compounds in MDS. Now, earlier studies that combined azacitidine with pevonedistat but didn't necessarily compare directly to azacitidine, or they weren't large enough to be conclusive, suggested that this might have a higher rate of complete remission and a better duration of response and event-free survival compared to azacitidine on its own. So this was a study presented at our annual meeting that looked at randomizing patients with MDS, AML, and CMML. It was looking for the time that it would take from enrollment until death or turning into leukemia. These are pretty balanced groups. This was a phase 3 study. Again, it's a late phase study that we were thinking about. This really is the power of a late phase study, because in earlier studies, we weren't sure. It seemed like this combination may be more better than azacitidine. What we found instead was that, it was pretty similar to azacitidine overall. There wasn't a benefit as far as complete remission rate. There wasn't a benefit as far as survival or duration of response. Now, they were pretty similar. There were maybe some minor differences. We talk about statistical similarity versus clinical similarity. The numeric survival was slightly longer in the pevonedistat and azacitidine arm, but the chance of that being random was too high to say that it's significantly better. And I think one of the big takeaways from this study is that both arms of the trial really got full dose azacitidine. So they got treatment at the full 75 milligrams per meter squared, and they got it consistently throughout the study. And so again, when we are approaching a clinical trial, I think about it in a box of 3 things. So if you're a transplant candidate and your goal is transplant, maybe you want to optimize your disease. And so that might be a setting where complete remission rate or exploratory markers of measurable residual disease matter a lot more, because I'm just going to give you this therapy briefly and then go to transplant. If you're not going to be a transplant candidate, maybe I don't care so much about getting a complete remission. Maybe I really care that you get a response that keeps you out of the hospital, that improves your quality of life, and that lasts a long time. So it might be more palatable to have a less toxic regimen that you can stay on for months and months and months. And I think increasingly we're looking at mutation targets. Should we start using targeted therapies like we do in AML and in other blood cancers or other cancers in general? So here, kind of thinking about, I want to go to transplant. Here's a study looking at Vyxeos, which is a treatment used for leukemia, acute leukemia, in patients who are transplant eligible and have higher risk MDS. And what you can see is that many patients had a response. So 20% or 1 in 5 got a complete remission, but another 60% or 3 out of 5 in addition had some decrease in blasts in their bone marrow so that they could potentially go to transplant. And what you see is that indeed that resulted in 75% of these patients able to go on to transplant and another 15% awaiting transplant. So there is probably a value for some of these strategies that might be a little bit more intensive up front, but then you can go to transplant subsequently. This is mirrored in data from another group. This is out of the French group. That again, similar study used this AML-like treatment, Vyxeos, and they also found that the response rate, that number of people who had a decrease in blasts, was very high. So nearly 80% of patients had a drop, or over 80% of patients had a drop in their blast count. And those patients conceptually could then go directly to transplant, because one of the metrics that we worry about sometimes with transplant outcomes has historically been excess blasts. Certainly that's been a challenge in AML, and we're trying to figure out if that translates also to MDS. I think another AML-like regimen that we use in MDS is a combination of azacitidine and venetoclax. Now, this is a combination that's approved in AML, and we are still exploring whether this makes sense in MDS. Is this should this be the new frontline therapy, kind of like pevonedistat was being explored? So there's a phase 3 study now randomizing people to get either venetoclax or placebo to try to figure out if adding this makes a big impact. preliminarily, our prior data suggests that, you know what, we can get, it seems like, higher chance of response. So 35% complete remission rate, 50% of patients having a reduction in blasts to get what we call a marrow CR. And the early data that we've seen from the frontline setting seems really encouraging that those responses can be durable. So the survival of patients who've been on some of these early studies has been really encouraging. And it seems not to matter, according to which mutation is present, who's going to respond and who may not respond. In general, there doesn't seem to be a mutation-specific pattern to responses to this combination. So all of these things are kind of favorable for thinking, well, is this a drug we could add to azacitidine across the board to really change how we manage our MDS patients with high-risk disease? A challenge that the phase 3 study will help us understand is that of sequencing, because at the same time as we've seen these responses in the frontline setting, we've also tested addition of venetoclax in the second line setting. And we've seen that you can really take people who had not responded to azacitidine, and historically, we don't have a lot of great options for them, but suddenly we can get responses in that group. And those responses can be seemingly durable with survival that seems to really stretch out for many of those patients. And so it brings us up to this question of, and here's another study presented out of data out of Moffitt. Is it better to start with the combination of azacitidine and venetoclax? Or is it better to start with azacitidine alone, get as much mileage as you can out of that, and then to add venetoclax? And I think that that depends a little bit on what we see out of the phase 3 study. I also think that this is increasingly an important question to ask about our studies. Is the goal to get to transplant, in which case maybe high intensity therapy up front makes sense? Or is it better to try to do something that we can extend our response to therapy as long as possible before we need to switch to the next thing, because maybe curative therapy is not within the goals of what we have. There are other agents that we're looking at in higher risk MDS. And so this is a study that was also presented at ASH that I've been involved in. It's looking at adding an immuno-oncologic agent therapy that targets a molecule called TIM3 that's involved both in the stem cells of the MDS patient, disease, as well as it seems to be involved in our immune system becoming kind of exhausted, unable to kind of surveil for cancer cells in our body. And so this adds that combination. And, in looking at this, there are a number of people with this combination who still get a response. But I think one of the other things we think about in disease is how durable are the responses? Can we really stretch out a response over time? Because, is that a way that we can prolong, especially for people who may not be able to go on to curative therapy, prolong responses so that they have a better quality of life and longer duration of survival? And similarly, in this study, we were encouraged because there are a number of people who had higher risk mutations. The response rate didn't seem to really vary according to mutation. And so maybe this would be another type of strategy that would not be restricted just to one mutation group, but would be broadly applicable to a lot of MDS patients if it does improve upon azacitidine alone. And I think another compound that was updated at ASH this year and kind of similarly showing how do we interpret these studies, what are kind of clinical trials that you might think about going on. This was looking at a therapy targeting a mutation, TB53, and adding a drug called APR-246. And we get a sense of longer-term follow-up. And I think this is an interesting study too, because it emphasizes the importance maybe of transplant. So just like I talked about, maybe for a transplant-eligible patient, you really want to get your disease in the best control possible before you go to transplant. This study with longer follow-up suggests that the people who had the best responses prior to transplant and then went to transplant, those were really the patients who had the best success long-term. And so maybe our treatment, our trial portfolio will change to kind of reflect these different goals of therapy. I think an exciting area of MDS is really how many emerging targets are being developed. And so often we think about targeted therapy in AML. FLT3 is a common target there. One of the challenges, for instance, in MDS, though, is that some of these mutations like in FLT3 or like in IDH1 or IDH2, they're relatively rare. Here's kind of a frequency plot of mutations in MDS. And you can see that FLT3, IDH2, those are generally less common in the patients that we see. More frequent are mutations in a compound in a part of the MDS cells or any cell called the spliceosome. The spliceosome has a role in a lot of cell processes. But what we found is that mutations in splicing are seen in over half of people with MDS. And so if we could target that somehow, that would be a really exciting way to have a therapy that now is valuable for a larger group of patients. And our group and others have identified a number of kind of Achilles heel of the spliceosome and have explored different ways to target it, either by directly targeting the spliceosome itself or by targeting pathways it depends on, like ATR. And so we were able to show some data from a study that we're looking at. So this is an earlier phase study, a phase 1/2 study, looking at can we give an ATR inhibitor to MDS patients, and then exploring whether there are some signals for response. And so here's an example of a patient whose red cells and platelets seem to improve with exposure to this ATR inhibitor, and also how we look at these individual plots, individual patient experiences, try to understand if a drug is active. Similarly, we're looking at other kind of combinations. There are a lot of pathways and signaling that are more enriched in MDS, but don't maybe have as much activity in other blood cancers or other cancers in general. One of those is looking at RAS or FLT3 mutations, and really that signaling pathway. FLT3 and Sybil are activating mutations. We see these mutations as people, as disease progresses from on treatment. So we often see their disease develop an expansion of a mutation in RAS or in FLT3 or some other clone that allows them to escape therapy. And maybe it makes sense to use these pills that target those pathways early on to try to see if we can get activity early on and suppress this escape mechanism. And so there are increasing studies looking at FLT3 or Sybil mutations, or these are mutation-directed studies. So again, kind of getting to the point from the beginning now, we want you to understand your mutation profile, your disease, so that we can tailor any therapy in that regard. Now, changing gears a little bit, trials for lower risk MDS are very different. When you think about how we manage lower risk MDS, again, this is a disease that people are going to live with for a long time. And so one of our goals is not to give you therapy that's too toxic for a long time. And also, really, the therapy should be directed toward the problem you have. So if you don't need blood transfusions, you don't need platelets, you have a good quality of life, it's unclear that we really need to intervene unless there's some other reason, some other risk factor that we're worried about. Most often, patients with lower risk disease will have anemia. And then our therapies and our trials are trying to limit that anemia, improve blood counts, reduce transfusion burden. And it's important to think about, well, what's the natural strategy for managing low blood counts? Often it starts with growth factors. And then there's an array of regimens, none of which work 100%, but often which we try for several months to see if they improve blood counts. And if they don't, we move on to the next. If they do, we often try to use that therapy as long as possible until it's clear it's no longer working. And then when people have multiple low blood counts, what kind of treatment can we give them? Do we need to think about treatments that we typically reserve for higher risk disease, including for some patients, even thinking about an allogeneic transplant, usually once they've been on therapy for multiple iterations. So in choosing a trial for lower risk disease, in contrast to high risk disease, really you want to be goal directed. Do I need transfusion independence? Do I have certain symptoms that can be tracked as a metric for how the trial is working? is there a disease complication that they're watching, like iron overload or bleeding complications, infectious complications, heart failure, or other cardiovascular complications? Because we have to have some metric by which to say this is working or not. So here are some example trials just to get a sense of how we explore studies in low-risk disease. Here's a study looking at an injection every 4 weeks. This is a similar mechanism conceptually as what a recently approved drug called luspatercept may target. This is an activin receptor type 2A. And this study is really for transfusion-dependent patients, so patients who have transfusion needs, and they're trying to see, can we improve the hemoglobin and reduce those transfusion needs? So here's an example of an early phase study where they are dose escalating to see what's the best dose to use. And here's some patients have already seen some reduction in their transfusion needs to 50 or even 100%. From their baseline. So the pre-treatment 16 weeks, 8 to 16 weeks, how many transfusions did you get then? And how many do we reduce it by? There's also some exciting data in lower risk disease that are looking at these targeted therapies. So here's a study that looked at using, again, a small subset of patients, maybe under 10%, maybe 5% of patients have an IDH1 mutation. But for those patients, if you've got IDH1 mutated MDS, they're looking at combinations with azacitidine for higher risk disease. Also for lower risk disease, just looking at what if we just give you this pill alone? And they found that in patients, again, this is cohort C, just low risk disease, they found that about half of them, a small number, were able to respond. And so maybe targeted therapies play a role. Same thing was seen with IDH2 mutations. Again, maybe 10% or less of patients with MDS have such mutation, but for that small subset of patients, if you have it, they explored combinations with azacitidine, as well as just in the low risk transfusion dependent setting. And again, saw that about half of patients with low risk disease seemed to respond to this treatment. And so increasingly, we're thinking about, can we explore targeted therapies earlier on, especially if that targeted therapy has a favorable toxicity profile. There are other studies that were presented at ASH that are looking at, how can we get around some of the complications we see? So lenalidomide has been around and used in transfusion-dependent MDS for many years. One of the challenges with lenalidomide itself is that it can cause lower blood counts, specifically lower platelets and neutrophil counts. Often that improves with dose modification or treatment holiday, but can we use something like a growth factor, L-trombopag, to try to balance those low blood counts and get patients to be more consistently on therapy, be able to see better responses? So here's an interesting study where they did combinations of the two based on the blood counts to see if they can maintain. But again, for a lower risk trial, really looking at symptom-directed or cytopenia-directed therapies. And here's another, kind of one of the last studies I'll talk about for lower risk disease, but should we be borrowing higher risk drugs and bringing them down into the lower risk setting? And so this is decitabine, but it's an oral formulation. So thinking about how often do you have to be in clinic? Well, this is a once a month treatment. You take a pill 5 days in a row. And what kind of responses can we see in that setting? And what they found is, a similar response that you might expect in higher risk disease. So about 1 in 4 patients had a complete remission. But then if you look at the broader response rate, it was a little over half of patients who saw a full some form of response. So there is some activity, particularly for people who have not just anemia, but maybe all their blood counts are low, but they're still lower risk MDS. Should we be using things like this where the convenience of being at home, at least for some of the chemotherapy dosing, makes it a little bit more favorable? So there's a lot of considerations when we think about a clinical trial in MDS, and how do we balance that? How do we think about the disease risk itself, transfusion needs, the time for a transfusion, but also what kind of burden does it put on you? And I think this is important when you're thinking about a clinical trial. Do I have a target? How much time would a clinical trial involve? What's the toxicity profile? Could I be putting myself at certain risk that's really undue for the risk that my disease presents at this time? And, trials are time and travel intensive. Does this make sense? If I'm only coming in once every 3 months, does a trial make sense right now? Or should I wait until my disease is a little bit more burdensome? So when I think about how to select a trial and things that you can think about, just first of all, what's my disease risk? What is the standard of care? So if I didn't go on a trial, what should I receive instead? What is my goal? My goal is transplant, and in such, any trial should be aimed at optimizing that or getting through to transplant. Is my goal really getting off transfusions? In which case, your trial selection might be different. Are there specific targets or mutations that my MDS has that I should be thinking about for a clinical trial selection? And lastly, what other considerations do I need to think about? What kind of burden would the trial put on me? And what kind of burden would it put on my caregivers, my family? What kind of time burden is it? Does it make sense to do? And so with that, I'm happy to take any questions. I hope this was informative. I think there's a lot of exciting developments in MDS. I think that hopefully what we see over the next 5 years is a real shift in how we approach MDS. And that's in large part thanks to patients and individuals who are involved in the clinical trial process. So thank you, and happy to chat.
Thank you, Dr. Bruner, for your wonderful presentation. And thank you all for joining us today. For those who haven't sent in your questions, please start submitting your questions in the chat box, which can be found on the bottom menu bar. And for those who want to revisit this recorded webinar, a viewing link will be sent to all registrants and will be available on the MDS Foundation website for on-demand viewing within 10 business days. So let's proceed to the live Q&A. Please bring your questions. Our first question is from an MDS patient asking if someone who has a low blast count at 3%, who considers themselves otherwise in good health, but who is not responding to any therapies or current clinical trials and now requires transfusions every 2 weeks, still considered low risk?
Yeah, that's a great question. Most of our risk scores are really meant to just assess risk, quote unquote, at the beginning of diagnosis. And so when you're diagnosed, it's trying to map out a course that your disease might take. I think that when people have been through therapy or have lived with MDS for a longer period, the nature of their disease can change. And often it is a time where you need to reassess. I often, when I have a patient who is initially low risk, but now they've gone through a number of therapies, their disease is not behaving as nicely as might have been before, think that's an appropriate time to reevaluate what their disease is with a repeat bone marrow biopsy, and typically with repeat molecular testing as well. And to get a sense of, what are the overall goals. I don't think it's unreasonable to think about treatments that are used in higher risk disease if there are no other obvious therapies for low risk disease, and if there's evidence that your low risk MDS is causing problems. So often that's represented by cumulative iron overload from chronic transfusion support. So for instance, I do have lower risk patients who have been through a number of therapies for low risk disease, but at this point, have still are requiring transfusions. And we may talk about something like transplant because, especially if they've otherwise are healthy and we're looking at many years ahead, transplant is a very reasonable consideration, or using a chemotherapy that might be used for higher risk disease, typically like hypomethylating agent like azacitidine or decitabine. So I think it's a good question. We don't have typically risk scores that are made to answer it exactly, but it's not behaving as low risk as it might have at the beginning. The new molecular IPSS is meant to be able to assess patients serially. And so that is maybe an advance that we'll see in the year to come.
Thank you, Dr. Bruner. The next question comes from Barb. She's been on watch and wait for 5.5 years and will begin cyclosporine and ATG therapy within the next 6 weeks based on a bleed she had this past September. She would like you to share a little bit about this immunotherapy treatment.
Sure. So it sounds like your treatment team has done a recent bone marrow, and there are some patients who will respond to immunosuppressive therapy. Typically, at least in our practice, those are patients whose bone marrow biopsies overlap quite a bit with aplastic anemia. We think that there's probably some degree of overlap between aplastic anemia and so-called hypoplastic MDS. And the people who are most likely to respond to immunosuppressive therapy have a lot of features of autoimmune cause of their anemia or kind of overlapping with aplastic anemia. So you might see something called a PNH clone. You may see, typically you would see a very low number of cells in the bone marrow. In that setting, it's reasonable to try immunosuppressive therapy. Most of the advances recently in immunosuppressive therapy have really been in patients who have more clearly defined aplastic anemia. Often that includes a triplet of therapy, including ATG, cyclosporine, and a pill called eltrombopag. And that's really a triplet of therapy developed in aplastic anemia. But there was just a study that showed that that triplet does have a higher response rate and more durable responses than our historical standard. So I think it's reasonable, especially if your disease has aplastic anemia features or is so-called hypoplastic MDS, to think about immunosuppressive therapy. And usually the triggers to start therapy are something like this need for transfusions or very low blood counts. Depending on your age, we sometimes also consider whether a transplant may be an option, similar to how we might approach aplastic anemia.
Thank you. The next question comes from Richard, who lives in Canada. He would like to know more on how to access clinical trials when you live in another country.
It is a challenge. It's a challenge that's been exacerbated by COVID-19 in general, because I think one benefit, I suppose, is that there are more virtual options and there's more ability to communicate with people virtually. Challenge, though, is getting around and traveling to a site, receiving care at a different site. That can all be much more difficult with the pandemic. I think that an important step wherever you are, whether it's another country or here in the US, is to first reach out and express your interest in clinical trials with your local hematologist or oncologist. The reality is that most clinical trials will require a number of visits, especially early on. And so if you're really distant from a site, you may have to think about what is practical for me to relocate if I'm interested in pursuing a clinical trial, and how does that make sense for my quality of life and my overall treatment goals. Because for many things, especially in the beginning of a treatment, when we're seeing if you get a response, it can be more complicated and require more visits to the trial site. I think that once you have a response, that's easier. Many times the number of visits decreases. If your blood counts are good, you're more flexible about travel, things such as that. But I do think that asking yourself, where can I go practically if I am not near a trial center right away? And often it is a few months at least when you're starting a clinical trial to be prepared to be near a different center.
Thank you, Dr. Bruner. The next question comes from Mark. He wants to know if you're aware of a clinical trial for one with low-risk MDS and myelofibrosis diagnosis. He's transfusion dependent and has had prior therapy with luspatercept, which was ineffective. And then it's two-part. He also wants to know, can one be treated for myelofibrosis while having MDS with ring sideroblasts?
Absolutely. It is some of these so-called overlap syndromes are increasingly recognized as separate entities. Often it comes down to your, a reinterpretation of the marrow at a site, and also kind of a better assessment of what the blood counts are. So do the blood counts look more like what we might see with MDS? Are there features of a myeloproliferative neoplasm that would make it more clearly a overlap syndrome? You can see fibrosis in MDS without it being necessarily a diagnosis of an overlap syndrome. Sometimes the mutation profile can also be very useful. And I have had, depending on kind of a reassessment, patients who fit into a myelofibrosis type of trial, patients who fit into an MDS type of trial, patients who, we really look for an overlap syndrome study. And I think that, even at ASH this year, there were a few studies looking at patients who have overlaps. The most common overlap is not MDS overlapping with myelofibrosis, but is chronic myelomonocytic leukemia, or CMML. And there are increasing trials in that space that are looking at CMML and other diseases along these lines that have features of both proliferation and dysplasia cytopenias. And so, I think I wish I could say it were an exact science to the disease going into a specific trial. I think that for many people, it's assessing what your main problem is right now and looking at trials, perhaps in both myelofibrosis and in MDS and in overlaps, and then exploring whether your bone marrow pathology or your other criteria would make you a candidate for that kind of study.
Thank you. The next question comes from Elodie. She wants to know, do you think CAR T cells could be a future arm for high-risk MDS patients?
Yeah, absolutely. I think that our experience with CAR T cells and other acute leukemias has been really encouraging. And as a technology, it's something that many of us are interested in advancing. Each disease that we use CAR T cells in has different strengths and weaknesses. And one of the challenges with MDS is that by the time you are diagnosed with MDS, typically almost all of your blood comes from the MDS progenitor cells. And so if you get rid of every MDS progenitor, it can be quite variable what kind of residual stem cells you have in your bone marrow. Another challenge that we've had in CAR T development in myeloid blood cancers, so MDS, but also AML, is that many of the targets are also seen on healthy cells. And so we can often wind up eradicating all of the good and bad neutrophils, myeloid cells in general, in which case you often need some salvage or rescue, like a allogeneic stem cell transplant. And so I think there is a role that we are continuing to explore with new CAR markers and new CAR metrics, and maybe new targets. There are some really interesting CARs that have multiple inputs that can maybe better distinguish leukemic or MDS cells from healthy. At this time, it's still fairly early days. I don't think it's wrong to explore. I do hope that in the years to come, we see that. It's just a little different bit of a challenge compared to lymphoid blood cancers, where you can wipe out all of your plasma cells or all of your B lymphocytes and still survive. It's harder to do that with myeloid disease.
Thank you, Dr. Bruner. Great answer. Diane has a two-part question. She has MDS with ring sideroblasts, and she wants to know, can low risk progress to a higher risk? or will she remain low risk? And the second part of her question is, what are the chances of her becoming transfusion dependent?
So for low risk disease, again, it's an estimate. I think that one of the challenges we've had is that nobody adheres perfectly to these risk scores. And there has been growing data that, how your disease behaves over time, a variable that we never had at diagnosis, is also really important to understanding what's likely to happen. I think the molecular score, which is builds upon a lot of our experience with molecular scores to date, will further help us prognosticate with patients. But there are patients whose disease will develop higher risk features. And I think that some of those are identified through the mutation profile. So an important thing that we do for every patient we see is we do, in addition to chromosome analysis and the standard bone marrow biopsy and aspirate, we also are doing a panel of mutations to try to identify if there are any higher risk mutations that we should be aware of and that we might, monitor you more closely for. I think the management up front, though, doesn't change. And so really the initial focus in lower risk disease is to, address any symptomatic blood count problems that you might have over time. And there are an array of treatments that are directed toward that. If your disease does show signs of changing, that means, we need to do a repeat bone marrow biopsy. And if it's not still lower risk features, then it may be time to change treatment direction. And I'm sorry, if you could repeat the second half.
She wanted to know what her chances are of becoming transfusion dependent. And then she also added, when you say having many years ahead, could that be more than the IPS's projection of 8.8 years survival?
Okay, sure. So for the risk of everybody has a slightly different path. I would say the most common course for patients with ring sideroblasts is that they eventually will become transfusion dependent with their disease. And so, yes, if untreated, that tends to be the course that can take many years. The IPSSR and all of these scores are averages, are medians. And so that means about half of the people have a shorter time, half have a longer time. We have to remember, too, that these are scores developed really in people age 70 and older. And so, median survival of 8 years may just be, that'd still be 78 or 80 on median. So 50% shorter, 50% longer. I think there's a lot of extrinsic variables that play that can contribute. And so usually when I talk to somebody, I try not to use numbers because those numbers are dependent on the group of patients they were derived from, but more, is this the type of MDS that you're likely to live with? And I think it sounds like that may be the case, that it may become transfusion dependent, but it's less likely to be immediate a threat to your longevity. Or is this the type of MDS that if untreated is going to start causing problems on its own within a year or two, in which case really that's a disease that we need to manage differently and try to change that natural course. And so I don't think there's an exact time. Many people do, half were longer than that. But it's just to give a rough guideline so that we can help people on their paths.
Thank you. The next question is from a low-risk MDS patient whose white blood cell counts and ANC platelets are the cell lines that are only affected. No external symptoms. They feel fine, not on any medications currently. They want to know what is the appropriate treatment for white blood cells dropping and platelets.
Yeah, those are definitely harder than red cell transfusion needs. Platelets, we can tolerate a very low platelet count. We can tolerate a pretty low neutrophil count as well. I have many patients who don't have infections, aren't having bleeding, and we simply monitor, and that can go on for years. When people are, have a platelet count below 20, it starts to get harder, especially if they're having bleeding issues. And there are treatments for that. A lot depends on how symptomatic they are, and also if you need other interventions, if you need surgery, if there's some other, if you have to be on aspirin for heart disease or other reasons that you need a platelet count higher than that. But without other indications, the incredible thing about the human body is we can really tolerate pretty low neutrophil and platelet counts. Similarly, a neutrophil count is just a number. If I have patients who really don't have any infections and they may have a very low neutrophil count, but we are simply monitoring. If things drop to the point that we need to intervene, then it may, the management is more varied. In general, the therapies that we use include drugs that try to improve the platelet count. There are growth factors, TPO agents that can improve the platelet count in some patients. Often you want to make sure you don't have an immune cause, something called ITP. And you also want to do a bone marrow biopsy often around the time that you're initiating therapy to make sure there's not some other factor like increase in blast count in the bone marrow or new chromosome abnormalities that may suggest that this is actually a disease that would require management like higher risk disease. But at times, patients will also receive hypomethylating agents or even think about transplant usually after the first, if they were low risk, usually at some point while they're on hypomethylating therapy. And so I think that it is less standardized when to intervene. Usually, though, it adheres to a similar metric that, we can monitor patients, but we may not want to burden them with toxicities of therapy if they really have no side effects of their low blood counts at that time.
Thank you. The next question comes from Siobhan. First, she would like to thank you, Dr. Bruner, for your wonderful information. She said that you mentioned low conditioning prior to allogeneic transplant when treating an early diagnosed high-risk patient, which showed showing a high percentage of relapse. She would like to know what is the percentage of relapse after allogeneic transplant?
Sure. These are all estimates, so they're not very exact. I think that in that study, there's a lot of variables at play. So that study that was looking at that was a study that randomized people between high intensity and low intensity conditioning prior to transplant. Now, sometimes we can't randomize people. So sometimes people will have heart or lung disease or other comorbidities where giving a high or age and just organ function, which prohibits us from giving high intensity ablative conditioning prior to transplant. And so to some degree, the question is what happens if you can't get that highest intensity therapy, if you get a reduced intensity conditioning regimen? And then several studies have tried to look at, well, what is the burden of disease prior to transplant and how does that influence relapse? I think this is not standardized yet, so I would not necessarily base my decision to go to transplant or not on this kind of data. But what they've found retrospectively is that people who had a lower disease burden before transplant or people whose disease gets eradicated shortly after transplant, so between day 30 and 100, those patients have a lower rate of relapse. And that kind of makes sense. If you have less disease going in or transplant gets rid of it, then it's less likely to come back. If you have more disease detectable prior to transplant and the threshold of what counts as more is not fully defined yet, or if you still have disease detectable 30 to 100 days out, then those patients are at higher risk of relapse, and the estimates are anywhere of relapse between 40 and 70%. A lot depends on the mutations as well. So certain mutations are unfortunately higher risk of relapse than others. So I don't think it's one size fits all, and I don't think that measurable disease monitoring in MDS is standardized enough yet. But I do think it is worth discussing disease optimization with your oncologist. And also, if you're looking at a transplant, talking about it with the transplant team, and what kind of conditioning regimen you might receive prior to transplant.
Thank you, Dr. Bruner. The next question is, what trials are there for patients that have high neutrophils?
Patients with high neutrophils, I guess there's two ways to think about that. One could be that your disease causes a high neutrophil count. There are some MDS MPN overlaps with that as a feature. So for instance, chronic neutrophilic leukemia or atypical CML, or MDS MPN unclassified overlap malignancy. In which case, the neutrophil count itself, usually mature neutrophils are not a dangerous thing. And it's more whether you have other blood count or blast count issues that are driving the decision to treat. Otherwise, in patients with MDS who do not have neutropenia, so have a normal neutrophil count, trials are still available, but usually they'd be based on another factor driving that trial. So it'd be due to the fact that you've got anemia that needs to be managed, or you've got really bad thrombocytopenia, or your blast count has increased. And then really the trials are targeting that. As far as when a white count influences therapy, usually, again, that's in these overlap syndromes. The most established is probably in CMML, or chronic myelomonocytic leukemia. And when your white count gets above the 30,000 range into the 40,000 or higher range, then in general, we do want to reduce that, most commonly with hydroxyurea or with chemotherapy called decitabine.
Thank you, Dr. Bruner. The next question comes from Jessica, and she wants to know, do you see that low-risk patients have several autoimmune conditions with MDS? And what medications are the best that might help MDS too?
Sure. It's an interesting phenomenon. We think that there's a dysregulated immune function in MDS, both that results in poor immune function and also hyperactive immune function, as is the case with autoimmune complications. What the best treatment is not clear. Generally, we try to approach them separately. So I usually work closely with a rheumatologist who's managing a patient. And my advice is generally, don't let the blood counts or the MDS limit your treatment decision. You should really treat them as you would whatever disease it is. And similarly, if there's an indication to treat the MDS, I usually use whatever therapy is indicated. So I might say I have pancytopenia and intermediate or higher risk disease, I might consider azacitidine. I might use growth factor support if it's mostly anemia, but I usually try to independently evaluate the two and treat them separately.
Thank you. Sergio wants to thank you for your excellent presentation. He mentions that you are in favor of therapy to reduce tumor burden before transplantation. In the last ASH, a study was presented that performing the transplant as early as possible has better results. You do not indicate upfront transplantation without previous therapy, and he wants to know what treatment do you recommend prior to bone marrow transplant?
Yeah, I think it's a case-by-case evaluation. Some of it's practical. When you meet somebody with new MDS, we usually meet with both the leukemia and the transplant team. But identifying donor is often not immediate. So I try not to delay transplant per se, but the reality is, if you've got higher risk disease, there are often indications that you'd want to advance to transplant sooner, especially for people where I'm doing a reduced intensity conditioning regimen. Often that is where having some disease optimization pre-transplant matters. Historically, we've known, for instance, if you have more than 10% blast, the relapse rate can be very high after transplant, so we try to reduce that. That said, we don't have a randomized study suggesting that that is better, but in general, if there are excess blasts, we try to get those down prior to going to transplant. Usually that would be azacitidine or decitabine based therapy prior to transplant. If there are AML-like features, if a patient had NPM1 mutated MDS, I might give them an AML-like treatment prior to transplant. But I'm not against going straight to transplant in some patients. If they really don't have other high-risk features that would make me worry that they'll progress within the time to obtain a donor, I don't think that's wrong. It's a challenging thing to study. The BMT-CTN study tried to evaluate that somewhat, but it's hard to know, is that cause or effect? So for instance, there was higher risk among patients who got azacitidine before transplant, but at the same time, that means their doctor thought that they needed treatment right away. And does that in and of itself bestow some risk? And so usually we're working pretty close with transplant team. And I don't want to, I think we should, as possible, we should try to get to transplant sooner if able. I think the biggest clear thing is the risk of the risk of the risk of relapse, and trying to assess what is the best way to go forward. Usually it's in that conversation, but I wouldn't delay transplant necessarily to give them treatment if they didn't need it.
Thank you for that very thorough answer, Dr. Bruner. The next patient comes all the way from France. She had RAEB2 MDS, had a 50% match in a stem cell transplant, but relapsed after 2 years. Then she had 9 months of azacitidine alone, then AZA and venetoclax for 9 months. Do you know any clinical treatment available in the last 3 months? And again, the patient lives in France.
I think that this is a space that we increasingly are seeing, especially with the approval of venetoclax in AML. Many patients have had prior venetoclax exposure. I think that, there are many trials in the relapsed refractory MDS and relapsed refractory AML space. It would be very important to know your mutation profile, because that can often inform which trials are available. I think for your purposes, a question would be where you can receive a clinical trial. There's certainly a big group in France, the GFM, that is highly involved in clinical research, and I'm sure that they would have access to guiding some of those questions. Most of the larger institutions here in the United States have a similar sense of trials. Often there are international liaisons with each hospital system or each group that can help review a case if you're considering something like a relocation for a trial for a period. So I think that this is a challenge we have, and there's certainly a lot of studies looking at this space. So it's probably worth inquiring with your local doctor, as well as regionally available trials, and it's usually institution by institution as far as in the United States their trial portfolios.
Thank you, Dr. Bruner. This is kind of related. This question comes from Gary, who had a very recent bone marrow transplant 3 months ago. And he wants to know if there are any clinical trials aimed at increasing the chances for optimal outcomes.
For transplant?
Yes.
Yeah, I think one of the spaces, for instance, where we're very interested is in this role of maintenance therapy. So for people who have high-risk disease, so say you've still got mutations prior to transplant, or you have a type of mutation in your MDS that makes us worry that you're still at a moderate to high risk of relapse after transplant. One of the spaces that I think many are looking at is, can we give you chemotherapy once your cells have engrafted, and to try to reduce the chance of you subsequently relapsing, recognizing transplant more as a continuum of therapy rather than the end. And eventually, you would come off of those therapies, but would it allow for more time for the transplant to mature, develop a graft versus leukemia effect, and could we cure more people? And so I think that there is definitely an interest in that space. There's also increasingly reported measurable residual disease metrics after chemotherapy that that we're looking at. So it is a little institutionally dependent, but that's a particular research interest that we have, and that many sites are involved in, this idea of maintenance or post-transplant therapy.
Thank you. The next question comes from a patient who wants to know if there are any trials to consider. She has MDS with ring sideroblasts and multilineage dysplasia, low risk, diagnosed in 2019, now 77 years old, female. Only platelets are trajecting down at 49. Other counts are stable. She has trisomy 19 mutation, SRSF2, P95, R102 deletion, and at 17% blasts. Had prior breast cancer with radiation and Arimidex. And again, she wants to know if there are any trials to consider.
Yeah, I think it's probably worth talking with your local oncologist as well. It sounds like you have an increase in the blast count. And so while you initially had lower risk disease, that would be a higher risk feature. And often we think about chemotherapy. And that might be why your platelets are falling. I think that there are a number of treatments. If you've not had azacitidine or decitabine before, there are many studies in that space, including several phase 3 studies as well as early phase studies. And so the key would probably be figuring out where you can receive such a therapy and or what's convenient to you. For those kinds of treatments, they really are a week of chemotherapy and multiple visits, usually at least weekly. So it is important to know kind of where can I live and be to be able to go through something like your clinical trial. But it sounds like you'd be eligible for a number. I'd probably start by asking your local oncologist and also kind of gain a sense of what would be practical for you as far as travel and the site of therapy.
Thank you, Dr. Bruner. We're winding down. I think we have time for maybe just 2 more questions. The next question comes from a low-risk MDS patient with low WBC, neutrophils, and platelets. Their hematologist says taking a second COVID booster will not help much against Omicron variants. He suggests using EvoShield from AstraZeneca, which just got FDA emergency authorization, but not approved. The website said there is some risk if you have low platelets, thrombocytopenia. What do you recommend here as to whether I should accept this approach or not?
It's a good question. And of course, what we understand about COVID management in MDS and AML is a constantly evolving thing. I'm recommending all my patients at least get their 2 to 3 dose primary series. So people who have immunosuppression or who are on chronic steroids or who have other reasons like chemotherapy did not mount a full response, they would need a 3-dose initial series. Other people who are not on any of those regimens, 2 doses would be the initial series. And then I'm also recommending they all get a booster, which would be 5 months out from their second dose. And so assuming that you've had your full series and booster, then it's a big, it's an evolving space as to what to do to prevent infection. Evishield is an option. It is a little regionally variable. Right now, for instance, at our site, we're prioritizing patients who have B-cell malignancies or don't have the ability to mount immune response due to heavy immunosuppression. I think it's a reasonable option if you are eligible. The concern about low platelets is immune-related phenomenon. It's rare. It could be treated with if it were to occur. So I don't know that I would necessarily use that to outweigh the benefit if it seemed like you're otherwise a good candidate for it. And there's a lot of reasons that people can be candidates. I think the other emerging agents that are really going to be valuable are the oral therapies, Paxlovid, and there's antiviral from Merck. Both of those are effective at reducing hospitalization. They seem to have an impact akin to Tamiflu, if not better, by their hospitalization rate reduction. And then there is also remdesivir, which also prevents hospitalization and severe disease. It is administered intravenously, though, and so it is a little bit more complicated. It's a 3-day infusion, so not every site has it. So, I think we're in a different era of COVID management. I think the main thing I'm recommending is that you have received your full series and your booster. We don't know yet if additional doses will be needed or will have value. So I think that that's to be answered. But at the same time, we have a number of options, and it's probably a little regional what's available to each site at this time.
Thank you. Our last question comes from Suzanne, 67 years old. She had a transplant at Moffitt in Tampa in late October. Her TP53 at transplant was at 93%. Her last bone marrow biopsy at 30 days, TP53 was at 50%. A new bone marrow biopsy is 90 days next week for the new number. However, they feel MDS will return at the molecular level. She now has mild graft versus host of the liver, no skin issues, and she's taken Vidasa and magrolimab. She was on the Vidasa and magrolimab trial prior to treatment. Now they want to start Vidasa or decitabine 1 to 5 days or 1 to 3 days, and then maybe NLI infusion from her donor if the graft versus host goes away. She did not do well with Vidasa and had no results. After transplant, they say Vidasa or decitabine may do better than before transplant. Can you expand on this or any other options for her?
Yeah, it's a challenging situation. We don't have a lot of great targets for P53. We're working hard to develop some. There has been in a growing literature that hypomethylating agent-based therapy, either Vidasa or azacitidine or decitabine, and there are some different doses to look at. There's 10-day decitabine, there's 5-day decitabine, there's 7-day azacitidine modifications therein. That can be effective. For some patients, we add venetoclax, although in TP53 mutated disease, it's harder to know how much benefit that adds outside of response rate. I agree with their concern that if you can detect the mutations after the transplant, we worry about the risk of relapse. And often that is a space where we're exploring maintenance-based therapy or early intervention therapy to try to reduce the disease or control it so that the graft can grow. Because the graft doesn't, your donor cells don't learn how to fight the leukemia right away. It takes them time to control anything, and you're on immunosuppression, so you're blunting that response. So usually we think of it as a two-pronged approach. We need chemotherapy to suppress the disease as much as possible, and we need the cells from the graft to mature and learn how to fight the MDS or leukemia as well. And so I don't think it's unreasonable to think about treatment. I recognize that it can be challenging to know if post-transplant is the same as what will happen prior to transplant. But there has been a modification of the disease, and in some ways it doesn't need to, you're trying to tread water or keep things steady so that the graft can work against the MDS cells. So it is a strategy we're often looking at. There are a number of trials in that space. I think it's reasonable to keep discussing that kind of option. We usually do a two-pronged approach, chemotherapy and then donor cell infusion in some ways to try to stave off relapse. But it is an area where I think all of us are working on new trials in that disease.
Thank you. Unfortunately, that's all the time that we have for questions. Thank you, Dr. Bruner, for participating and your time and effort that went into preparing for this webinar. It was a great talk and very thorough overview of the disease landscape and emerging treatments. And thank you all for attending today and for your great questions. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with the link within 10 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.